Hi, everybody. I'm just waiting for a couple more people to join. Can you guys hear me?
I can hear you. Hi, Dr.
Very good, very good. Hi, Cora.
How are you?
Good. I think some people are still joining, so I'll just give it a couple more seconds.
Yes, we have more people joining, so we can wait. I turned on my video, but
Do you guys have any idea how many people are going to be joining?
I would say usually when we hold these events, like we have about maybe 30 to 50 on campus, so we might see maybe around that number.
So currently we have 14 people.
Okay.
So I'll give it a couple more minutes and then we'll get started. I hope you guys are doing well and enjoying the sort of break. Not quite sure, where you are in the world. Probably not in New York. Maybe some of you are.
I'm in New York.
Yeah.
Still here. I think a lot of our classmates went back home though, to their respective states.
Okay.
There's a few people here in the city, but let's see.
So I haven't ever shared my screen before, so I'm gonna try to do that, but if I can't, I'll just talk through it. You guys will have access to the slides. I'll send them to you guys because there's a lot of things that I wrote in there that you literally need to go to. So I don't want you guys to like fiercely be writing. I promise I'll send you guys the slides.
Thank you. You know how we are. We want to write everything.
And I actually want you guys to just listen. And I don't know also if there's I haven't used those features in Zoom where you can just type in questions.
I'm sorry, I got disconnected for a second. What were you saying?
Is there a way to, yeah, there's a chat. Okay. So you guys can always put in questions in the chat. I have the chat up also. So I'm gonna start in about 3 minutes or so because people are still coming.
Okay.
Hi, Dr. Amala. I just wanted to say hello. My name is Robin.
Hi, Robin. How are you?
I'm not tech savvy whatsoever, so I'm like, this is my first time being on like video and like talking. So this is exciting for me, and we're just so thankful that you came and are talking with us. We're so excited to meet you. You're so interesting. I've been doing my fair share of stalking on you, and I'm really looking forward to hearing what you have to say.
Oh, no problem. I'm also going to give you guys access to a lot of things, including my my email.
Okay.
So everybody that comes on here. So if you share the PowerPoint that I give you, please take out my email. It's just for you guys.
Okay, yeah, I will do that.
There's a lot going on. So even when because I'm going to try to post this on my YouTube, I'm going to crop that part out so that they don't, because I'll be getting all these crazy emails. So
all right, we'll take care of that for sure.
Yeah, I second that. Thank you so much for taking time out of your busy schedule. And
oh, no problem. I'm just going out to try to find my PowerPoint.
Okay.
And then I'm gonna try to see if I can share the screen. I know there's a way to do that. If anyone knows how to do that, please let me know.
Let's see. What device are you using? Is it
it says, I'm using a Mac. It says share. So I think I can share. Yeah, okay, I figured it out.
Yeah.
Figured it out.
Hi, Dr. Rumala.
Hi, Talu. How are you?
Good. How are you?
Good. It's very nice to meet you all. I'm very excited that you guys are here. Yeah, and everybody else out there, anybody that wants to say hi while we're waiting, I would love to say hi to you.
Don't be shy. Chime in.
So if people don't want to talk, while we're still waiting, there's one more question I have, which is, what years are you guys? So you guys can type in the chat, like what year you guys are so that I can sort of get an idea of, so we have first and second year, okay, first year. Hey, first years, oh my God, you guys are, so first and second years is what I'm seeing. Oh, incoming, awesome. Awesome, awesome. Well, I went to school very close to you guys. I went to school at Rowan in South Jersey. I stayed in South Jersey the whole time because we had the option of going to North Jersey also, but I stayed in South Jersey. I stayed in the Philly area. At that time I was engaged, so my ex-fiance was in Philly, so I stayed in that area. My brother is a New Yorker, so yay, I definitely go to New York quite a bit. So I think I'm gonna get started. So let me share the screen with you guys because I know you guys are tired of seeing my forehead.
Dr. Romola, do you want me to proceed with the introduction or?
Yeah, you can go ahead before I get started,
okay.
yeah.
All right, I'm very excited to introduce my mentor, Dr. Romola. So she is an OBGYN with a practice in Mansfield, Texas. Dr. Ruth Romola provides evidence-based medical care to women of all ages at all aspects of their lives. Dr. Romola specializes in the management of pregnancy, fibroids, PCOS, sexual dysfunction, and menopause. Dr. Romola has won several awards that demonstrate her exceptional clinical skills and service to her community. These include 2020 National Minority Equality Forum's 40 Under 40 Leaders in Minority Health, 2020 Fourth Worth Magazine Top Docs, Tarrant County, OBGYN, 2020 Texas Super Docs Rising Stars, and 2020 Women in Medicine Top OBGYN Fourth Worth. Wow, that's amazing. In addition to her clinical duties, Dr. Romola also serves as the entertaining hostess of the Pretty in Pink podcast that you should listen to, a modern woman's guide to health, from love, sex, and relationship to managing personal finances. Dr. Romola interviews inspirational female experts, guests who explore a broad range of topics that affect women. Armed with her varied experience in medical training with the Romola DO, Dr. Romola MPH, NCMP, invest a lot of time and resources to preparing the next generation of physicians for their careers through one-on-one mentoring and video series hosted on several media outlets. So to learn more about her work, we can share her social media handles and YouTube pages as well. So,
yeah, those are gonna be at the end.
yes.
Thank you so much, Cora. I love you,
Thank you.
Cora. Thank you so much. Now, can you guys see my slides?
Yes.
Yes, okay, good. So I'm gonna go to the presentation mode. Did that work? Okay, great. So becoming the perfect OBGYN candidate, that's literally what I wanna talk to you about, but you know, your first and second years, and I want you guys to be open to wherever life takes you. If it ends up in OBGYN, we will be happy to invite you into our career field. But if it doesn't, you can use these similar things for any specialty and subspecialty, because remember, with OBGYN, there's a lot of subspecialties, and I can talk about that. So my plan is to spend 25 to 30 minutes going through like these slides and then give enough time for a lot of questions because I want to answer you guys' questions. So one of the things I wanted to say is NCMP means National Certified Menopause Practitioner. So a lot of the times when people finish residency, our residency population is usually young and broke, because those are the people that are going to let residents take care of them. So we don't get to learn a lot about menopause. So last year, I went through the certification process, and that allows me to really focus on the menopause menopause group. So that's what that is. Okay, So what I want to cover today are the following. I want to talk about being a DO and really focus on that because you guys are going to be DOs. And then what you should do during the first and second year. I kind of got that from Cora, that was first and second year. So we'll talk about academics, COMLEX versus USMLE, and both. I took all 8 of them. So I can tell you what they're like. I did say I'm 34, so I took them, I think I took step 1 in 2011. So it's been a while. And then we'll talk about research, community service, what I call the golden summer, which is the summer between first and second years. Unfortunately for you guys, it may not be as predictable because of the pandemic. I'm going to group third year and the acting internship together. Letters of recommendation, interviewing. I'm not going to talk about interviewing very much in detail about the actual interview process because I have a YouTube video on that, so you can check that out. And then how to prepare a rank list and what you need to do to prepare for residency. During the third year in the acting internship, there is a list of like things that you can read, resources and stuff. They're all going to come at the end. And that's why I want to give you guys this list so you can use that to help you kind of get ready. Okay. So come on. So you're going to skip to, great. Okay. So the DO. So when I was going to osteopathic school, so I got into 4 MD schools, 3 DO schools. My school, PCOM, and PCOM, Georgia. So my mom was like trying to help me figure out where I was gonna go. And she told me that if I choose to become a DO, I have to be proud and never regret it. Never be in a situation like, oh my God, I didn't match because I was a DO. I didn't wear it with pride. So I actually have my name, my DO name on everything because I'm such a proud DO. I love the training that we get. And I think that the MDs have kind of moved to the similar training except for OMM. So I want you guys to be proud. Don't hide it. Don't be proud of who you are as a DO. You bring something different to the table. There are actually patients that look for you. So don't be like, this is not a blemish on your CV, okay? So some of you went to DO school because you didn't have an option. Let's just be real. And maybe your MCAT score wasn't high enough. Maybe your grades weren't high enough. Maybe it was in-state tuition. Whatever it was, that's fine. We already passed it. You're already going to get the DO degree. So we're not gonna want to be an MD. So let's start there. And so employability, no one knows the difference. Now they put MD/DO on everything. So you're going to get employed. That's not going to be a problem. So do you need to perform differently as a DO student when you're trying to get into residency? I actually think you do. Unless you are planning on going to a DO program, which is also an option. But, you know, it's also kind of different now that they're doing the merger. But I do think that in the beginning, you guys are kind of like the scapegoats. You do have to perform in a different way. Half the time, they're not gonna remember if you're a great student. Now, if you have some issues, then they'll start to be like, oh, the DO student has the issues. So be wary about that. So I am a minority in every sense of the word, except for my sexuality and my disability status, right? I'm a Black woman that's young and a DO. So at baseline, I stand out, right? So, but I don't ever want to, my goal was never to stand out. I didn't want to stand out for being exceptional, and I didn't want to stand out for being horrible. I wanted to be somewhere in the middle and then kind of edge out where you remember me. Now, I don't think that ever worked. I think I stood out whether I wanted to or not, but that was always my goal. So I want you guys to like really work on making sure that you're an exceptional student, because the more exceptional you are, the better you're going to be when you're going to be a better doctor to begin with. And that's the goal, okay? So one of my biggest regrets was that I did not pay attention to OMM and NMM skills. And now I have a lot of chronic pelvic patients that I was like, man, if I just remember how to do myofascial release of the pelvic floor muscles, I won't have to send this person to PT. But I wanted to be a dermatologist all of medical school up till I actually did dermatology. I was like, whoa, no, this is not me. So I was like, what is a dermatologist going to use OMM for? I just try to get through it. And so never do that. That's why I said to you in the beginning that even though you want to go into OBGYN, keep an open mind. Don't cut off any skills, any educational opportunities, any webinars. Don't limit yourself. Let me make sure nobody else is in here. Don't limit yourself, because if you limit yourself, you're not going to have the flexibility of knowing these skills, and no skill is wasted. So that would be my thing about OMM. Pay attention. So academics, first 2 years, because you're going to start applying, you really need to do, shape your first 2 years in such a way that you're an attractive candidate. I'm not sure, does your school, I don't know if anybody can respond to me, but does your school do honors and high pass, or just pass fail?
We do right now. We have a grading scale, and then this semester is pass fail.
Okay.
Yeah.
So obviously this semester is going to be a wash, just pass. But if you can honor stuff, honor them. There's some, if you have so the way that we used to do our exams, I think it's changed now, but we used to do all our exams as a block, all at once. So if you have to prioritize, first year, you need to prioritize anatomy and anatomy, really, is what you want in first year. Second year, pathology and pharmacology. Those are the ones you want to prioritize, because you have to learn how to prioritize. And if you're going to look for something that they look through your transcript and they're like, oh, they honored this and they honored that, that's kind of what you want to pay attention to. Third and fourth year is going to be your specialty of interest, which is OBGYN and surgery and medicine, internal medicine. So if you're going to look to honors and high pass, the key ones. It's great to honor histology and microbiology, but they're not no one really cares, if that makes sense. So look for every help that you can get. If you need a tutor, look for a tutor. If you do so well that you can become a tutor, become a tutor. Because the more you teach, the more you're going to know. And then it's another thing on your resume. And as you can tell, I won 4 awards in 2 months. I am all about building the resume. And I own my own practice, but I'm still all about building the resume, right? So always think about, what is it that I can do? How can I phrase this so that it can get on my resume? I'll give you an example. I am part of the Women's Health Advisory Board for my town, right? And at first, they didn't want to give it a name. They just wanted us to meet and give up our precious time. And I said, absolutely not. We're going to call it something. And then I'm the only OBGYN on the board. So I said, you guys are going to make me the chair. If not, I'm not coming. And now I have something else on my resume, but I could have just gone. I was going to go anyway, by the way. I sound threatening. I'm not at all. I was going to go anyway. And all of this was done via email. So they didn't know whether I was mad, upset, whatever. They just gave me what I wanted, because you're valuable. So they needed what you bring to the table. So, someone else is here. Great. Let me add them. Oh, someone asked the chat. Sorry. I'm going to answer that question really quickly. Oh, I can't see it. Anyway.
I think they're just saying that someone is waiting to get in. So.
Oh yeah, I just admitted them. There were 4 people. All right, cool. So where was I? Okay, so make sure that if you have an opportunity to tutor, get it on your resume, make sure it's there, okay? It shows that you have something to bring to the table. the biggest thing you need to do during your first 2 years is establish your learning style and improve your learning style. So coming from high school to college was a different kind of learning style that was necessary. From college to medical school, there's a different, or master's, whatever you did, there's a different type of learning style. Figure out your learning style for medicine. It will change from the first 2 years to the last 2 years. But some of the things that I did is, you know, I used to never attend lecture, except it was OMM, because I hated the idea of like not knowing things and everyone else is answering the questions. I felt very intimidated. So I would go to Starbucks all day, and I spent way too much money on Starbucks and I was broke as hell. But I would listen to the lectures. So I was always a day behind. I will listen to the lectures. I will spend my time. I will stop. I will do what I needed to do. And then I will have enough time to pause and reread through things. But that was my way of doing it. So figure out your learning style and how to improve your learning style so that it becomes like clockwork. One of the things I want to encourage you to do is learn how to optimize your memorization skills. There are lots of YouTube videos on how to do that. Coursera, Skillshare, you can learn how to optimize your memorization skills, and also learn how to read faster. Those two things are like things that will help you throughout your entire career, because you're going to be, I read articles every day. So you're going to be reading it all the time. So you want to make sure that you optimize that, okay? So the next thing is COMLEX and USMLE. Should you take both? I think that you guys are in, I've always been a proponent of taking both. I can't lie to you. The reason why are multiple. First of all, COMLEX is trash unless they've changed it. It is trash. Like, it literally is a question like, can you think about what I'm thinking about? Like, no, I can't actually, because I'm not you. But USMLE is more straightforward. So a lot of people tend to do really well on one versus the other. Some of the things that can optimize you doing well on COMLEX is to, on USMLE and COMLEX is timing. Do not keep a wide amount of time in between, because you burn out. You burn out. You're like, you know what? I don't even care. I'm just going to take this exam. Because if you're studying for 6 weeks, 8 weeks, 12 weeks, once you finish, it's like running a marathon. When you're done the marathon, if somebody tells you have 2 more miles to go, you ran 26 miles. If someone tells you have 2 more miles to go, you're like, negative. So that's the same way with COMLEX. So I will encourage you to try to keep the timing in between both really short. So I took mine a week apart. Some people need 2 weeks. Everyone's timing is different. I was over it. So that's one way to optimize your score. The second is make sure that, I don't know if it's still green, the Savarese book. I feel bad for Coco Bianco or whoever else wrote that book, because no one ever remembers their name. But they run into the et al. But
it's still green. Yeah.
What color is it?
It's still green.
Yeah. So Savarese is your friend. Know all the counterpoints. They're like things that are like memorized, and they give you, because for me, COMLEX, 25% of questions come straight from Savarese. So it's like every 4th question. So make sure you know, like, do not sleep on it for step 1 and step 2. And then I think you need both CommBank and UWorld, because the questions are different, like really, really different. It's similar material, but different questions, style, if that makes sense. Make sure you do a lot of practice exams. When I only studied for 6 weeks. I can't do more than that. Oh my God, I would kill myself. But so when I studied, I would do every weekend, I would do an NBOME exam, and I would do an NBME exam every single week. And the reason why you want to do a lot of exams is you don't know what it feels like to be taking an exam for that long until you take an exam for that long. It's literally like people who run track, like you practice like your relays, you practice your meet, you practice the same kind of event in the same way with the same kind of weather at the same timing. So you kind of want to do that. So I would do the discipline of the timing, taking the breaks when they tell me I can, not going back and looking at the questions. Like, you really need to do that so that you get ready to optimize your score. So step 2 timing is a little bit different. If you crush step 1, you might want to wait on step 2, so that step 1 is what they make the decision on. Step 2, if you did okay or didn't do as hot on step 1, then you want to take step 2 before you apply, because then that shows them that you made some progress, if that makes sense. All is never lost, no matter what. I'm telling you the optimal, but I know people who have, like, I literally know someone who's failed every single step and is a board certified ObGyn. So it's not the end of the world, but I'm trying to tell you the optimal way, okay? And then step 2 is very different from step 1. In COMLEX, step 2 really focuses on really well-defined things. So for instance, psych, all the disorders are defined. So a histrionic person is a histrionic person. That's what it is. A narcissist is a narcissist. A bipolar personality disorder is different from bipolar. Like, it's a defined thing. So you want to know those 3 things, those 3 subjects, because they're defined. Okay. Placenta previa is defined. It's different from placenta accreta. It's different from a placenta increta. Those are defined. PEDS, milestones, are defined. So anything that's defined, interoception is defined. Omphalocele, gastroschisis, all of those are defined. So you want to know anything that's defined, particularly for COMLEX. And those were the 3 most common things. And some people will tell you that, oh, they had only neuro questions and OMM. And the person right next to them had only psych questions. Like, so that's how COMLEX is, unless they've changed the format. But those 3 things you want to really know. Anything that's well-defined, you need to know. So research, community service, should you do both? So it depends on what you want to go to, and I'll explain what kind of residency programs at the end. But research is more, okay, I'll actually just say residency programs, especially in ObGyn, are split up into 3. They don't actually say that, but that's what it is. Community programs, communiversity programs, and university programs. I think I made up communiversity, but whatever. So those are usually programs that are a mix of community programs and a university program. That's what I went to. Georgetown is a communiversity program. It's now probably just a university program, but when I was there as a communiversity program, they were trying to get to a university program. So university programs have a lot of fellowships in their program. Community programs are really prepare you to be a great community generalist. So if you are going to a community program, they weigh research a lot lower. If you're going to a university program, they weigh research a lot higher, okay? There are pros and cons to each one. The community programs, because there are no fellows, you do a lot more cases by yourself. So when you finish, you're ready to do a case. When I was, like for my residency program, when I was there, there were no minimally invasive GYN, and that's the only fellowship that I would have gone to if I wanted to go to fellowship. I kind of went to one that was unaccredited, but ended up doing one. And what ended up happening is that we didn't have any fellows, so I did like 25 laparoscopic myomectomies. Now, you don't even need 1 to graduate, right? But now I feel comfortable doing, because I didn't have a fellow. Well, the year after me, now they have a fellowship. Well, you can ask anyone graduating, they did 0, right? So that's the difference. And so that's what I would say, like, if you're thinking, okay, I want to go to this top name Duke or whatever, then you need to do research, because you need to be competitive like everyone else. If you're not quite sure and you get the opportunity to do research, that's fine. But if you really think you want to go to a brand name university, big program, you need to do research because they actually weigh it really highly. And I noticed the transition as my program was going from university to university program, that they started paying more attention to research. And research can be even like case reports, case series. You really need to find out if they don't do a lot of research in your school, which I'm not that familiar with it, then I would ask your OBGYN like chair, is there somewhere where they do like that's close enough to you where they're doing research? And then you can look for yourself, right? So my medical school did not have a dermatology program. So when I was in medical school, I thought I was going to do dermatology. So I reached out to UPenn, which is close to me. And I did my year off. I did a whole year of dermatology research in Botswana. I lived in Botswana for a year. So in between third and fourth year of med school. Well, I didn't go into dermatology, but it still worked crazily good for me in many ways. Number one, you know, it was a talking point in every interview. Number two, I had publications from it. Number three, I had the best experience of my life. I went to 12 African countries. I'm Nigerian, but I'd never gone to anywhere but Nigeria and Ghana. So I ended up going to all these other countries. So the experience was great. But I did a lot of legwork on my own, finding these people, driving out to Philly, parking, like, you know, I remember then the toll was like $5 and $5 was like half of the money that I was worth. So it was a lot of sacrifice. So you might have to do something like that, okay? And I remember even first year of med school, I used to drive out to middle of Delaware to do dermatology research, salicylic acid research. Well, all those things went on my resume and my CV, but they were outside of my school. My school didn't know. The closest we had was pathology. So I used to go and practice dermatopathology with my pathology professor, and he would say stuff like, he'll get so excited and be salivating when he was talking about like the palisading histiocytes at the derma. I'm like, I don't know what I want to do. I just want to take care of people's skin. But, you know, that's how I found out that really wasn't for me. So the more immersed you get into it, the more you'll find out how much it is for you. And then if you cannot find research, but you want to go into one of these big programs, one of the things that you can do is a quality improvement project. So one of the biggest things that are big in OBGYN right now is postpartum hemorrhage. So like looking for postpartum hemorrhage, like quality improvement, that's an option for you to work on. Talk to your chair. One of the things that I never did was I never built relationships at my school. Horrible idea. I did not. No one knew I was going into OBGYN. When I got into OBGYN, they were like, wait, what? So really try to build those relationships. That also helps you win awards because they didn't know that I would. Things like that. So in retrospect, I was like more in my bubble than in my shell because I never really went to school. I would just sit in Starbucks. I mean, my school was Starbucks, you know? So, and then if you get into clubs, that's helpful. Again, something else on your resume, and you learn leadership skills, especially if you're in a leadership, level. I'll get to questions, I promise. I see them coming up. I will get to them. So the golden summer, which is not really golden for you guys, which is between first and second year. It's like your last summer of your year, blah, blah, blah. So I think your goals need to be threefold. They need to be professional goals, emotional goals, and financial goals. So you need to try to find a position that's going to help you, that's going to at least optimize at least one of these, but if you can get one that has a little bit of all three of them, that would be perfect. For instance, I worked for the National Youth Leadership Forum on Medicine. So what that is that I don't know if anyone is familiar, but that is a program that kind of helps pre-meds get an immersion, a 2-week immersion into medicine. So I was the coordinator for that. And I basically got to stay at school. So I already had an apartment. That was it paid me. They paid me like maybe $3,000 for 2 weeks. So that was financial. Professional was great. It went on my resume. And emotional, it helped me because it was something that I enjoyed. And it only took 2 weeks out of my summer. So I was able to travel, see my parents. So that met my emotional needs. Make sure you plan really, really early because you're competing against everyone else. One of the biggest themes in medicine is plan early. Plan early. Like, take your time and look at deadlines for things. Plan early. I'll give you an example. I applied for a program that is, the program actually starts July 2021. The deadline was February of 2020. That is medicine. So plan early. It's not a year, it's like a year and a half. So as soon as, like, I really tell people, as soon as you get into med school, try to plan for the summer. Now for you guys, we're already here, April? So if you don't have something, keep looking because people might change their plans based on the pandemic. But going forward, always plan early. Always think 2 steps ahead. If you're not a great planner, which I am baseline a great planner, my boyfriend will kill me because I plan. I mean, I literally know when we're getting married, he just needs to show up. So, like that's how much I plan. So that's how you need to plan in medicine because almost everything is done 18 months ahead. And if you wait, you're going to be caught off. Okay. Some of the things I really encourage is travel for several things. It looks wonderful on your resume and it's a talking point at interviews, and the experiences are to die for. And once you get into residency, you get 1 week off at a time. You may never get to get the travel experiences that you really want to get. So, and then you get into the real world and you have a lot of money, but you can't go anywhere. So, similar thing. And then the one thing I want to say is if you are a first year, do not study for step 1. Then you'll burn out. Enjoy your last summer, okay? So 3rd year and acting internship together. These are rules. Introduce yourself to everyone. You do not know who's best friends with anybody. Like, when I was in residency, my best friends were like the cleaning girls and the janitor, and they will come and be like, yo, this resident, this interviewee, don't even worry about her. Like, she's so rude. She just walked by us. Like, you don't know who is who. I have heard of program directors pretending to work a lower, like, service job to find out who's who. Okay? Smile. Make sure you smile. That is it's a universal way of softening any kind of wall. Make sure you stay engaged, like, in what's going on. If you're taking care of patients, make sure you stay engaged. Like, what time is what. Like, be alive, like, be in it, okay? Do not show up late. Please. Not ever, 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 ever. Don't show up late because think about it. I'm a surgeon, right? I do 90% of what I do is GYN. So I do a lot of surgeries. I only do about 10% OB. So, and prior to this, I did, like I told you guys, I did a fellowship. So all I did was surgery. So what I would say is show up. Like, if you can imagine, if my patients are there, I have a 7 o'clock case and I show up at 7:30 or 7:15. Like, so your whole life, you're going to have to, if you don't wake up early, learn how to wake up early because everything in OBGYN is early. I think it's probably the most time-consuming, sorry, let me make sure I know the time. Okay. I think it's the most time-consuming part of a residency program because you have all these postpartums to see. You cannot determine how many patients are going to deliver in one day. Okay. Your job as a medical student is not to stand out. Your job as a medical student is to make your team stand out, is to make your intern stand out, is to make your senior residents stand out, is to make sure that the patient is well taken care of in the little ways. It is not to make sure that people remember you. It's not to answer every question. If you know something about a patient, it's much better that you tell your resident instead of withholding the information so that you stand out at rounds, if that makes sense. Make sure you talk to seniors, defer to them. Hey, I want to go here. Is that okay? I want to take care of this patient. I've noticed this. Do you think it's a good idea for me to do this? Make sure you're not one of those students that is in the middle of taking care of a patient. That's when you kind of talk about the things that you want to talk about. Like, for instance, saying something like, oh my God, is that psoriasis? Like, bruh, that happens all the time actually. And or if a resident or an attending allows you to check a patient, right, when they have an epidural, like you want to check it, walk out, because they're probably going to say your name is Dr. blah 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 that you check it. You don't want to, you know, do a Heisman dance because you got it right. You know, like those are etiquette things that you don't really think about how the patient sees it, because this is people's real lives. These are people's real pregnancies. Like, this is not for play. These are real, okay? Oh, shoot, I have to admit someone. Okay, great. And guys, I don't have patients in the afternoon, so I'm gonna keep going till you guys leave. So never, ever, ever complain, ever. I actually got that part from one of my friends who used to be like, that's her pet peeve. And it didn't really bother me because I complain a lot, but never complain. And you can complain at home to your friends and your parents, but don't complain. And realize that a lot of the times the residents are really stressed. They're working 100 hours. You work your shift and you go home. Many of them don't work their shift and go home. Many of them work their shifts and then work their weekend shifts and then, you know, study and then have families, try to take care of their kids, because they're older than you, right? Most of the time, not always, but many of them have like families and other things like that. So you want to make sure that you kind of aren't complaining like, oh, I didn't get to do anything. Just stay engaged. After a while, people will start to get you in if they want to. Whenever you have downtime, always either practice suturing, knot tying, or read. If you notice that your resident is pissed off that day because maybe they got yelled at someone or they're getting a divorce or whatever, because life is happening at the same time, make sure you're not like, hey, can you teach me how to suture today? Like, you know, read the room. Read the room. There are wrong questions, right? They say there's no wrong questions. There are wrong questions. Wrong questions are anything that you can Google. Anything that's a definition that you can Google is a wrong question in medical school. What is a right question? A right question is it's a question that needs explanation or experience to answer. You can Google something, or you can go on ACOG and you can find the answer, then it's not a good question. But if you're asking me, Dr. Rumla, I noticed that you did not exteriorize the uterus. And the last couple of people that I've seen, they exteriorize the uterus. They don't sew the uterus in the body. Why do you do one versus other? That is a good question. But if you ask me, Dr. Rumla, what are the layers of the abdominal wall? Excuse me? You don't know how to use your Google? So that's literally how that works, okay? And then read the right things. I'm gonna tell you guys what the right things are at the end. Always know where you're supposed to be. So especially third year, they might tell you you're going to ultrasound one week, you're going to REI the other week, you're going there, you're going to GYN surgery. Make sure you know where you're supposed to be, and don't be showing up to another place right on time, but right wrong. Like, you want to make sure that you are where you're supposed to be. Sorry. Writing a recommendation letter. Or asking for a recommendation letter. The goal of a recommendation letter is to be a bridge between your academic performance and your personality. So you need to make sure that the person who's writing your recommendation letter knows both of those things, okay? Do they know how well you performed in your rotation? And can they talk about your personality slightly? And the way to do that is when you're around people, ask them questions. Everyone likes to talk about their kids. They like to talk about their pets. They like to talk about the things that they like to do. And then form your parallels. For instance, if you both keep orchids, now that's something you can talk about. Oh, do you put an ice cube in it? Oh, do you use warm water? Oh, doesn't it direct sunlight? Oh, when do you trim it? Like, those are things that, you know, if someone wanted to talk to me, I raise orchids, so we would talk about that all day. But then I can say things like, this person is caring, you know, like I can talk about the person beyond what I saw them do, beyond them cutting my suture perfectly. You know, like you want them to be able to know a little bit more about you. Usually you need 3 letters of recommendation, so always think about that. I tell a lot of my mentees to do wherever you did your 3rd year rotation, the chief of surgery, if it's your program, try to get, you know, either like the chief of GYN or the program director there, because those people usually know how to write recommendation letters. And let me tell you something, recommendation letters, there are levels to it. So there are some recommendation letters that will say, this student is great and will do well anywhere. If I told you that, you'd probably be like, all right, that person's cool. No, they're saying will do well anywhere, meaning we don't really care to keep her at our residency program. If they say this person is the top 1% of the students I've ever worked with, we would love for her to stay here. Now that's an exceptional letter of recommendation. If they say this patient will do, or this student will do well wherever she goes, they don't want you. That means you're like a C-level person. They'll do well anywhere but here. So there are actual keywords that you see in like recommendation letters that is like a professor talking to another professor, or a program director talking to another program director. If you read it as a layperson, you didn't see all those things, but they have speeches. And why am I telling you that? I'm telling you that because you do not want someone like me to write your recommendation letter for residency. You don't mind me, I could do it for getting into medical school. I would be great. But you want someone who already has some academic clout. I'm not an academic, I've just signed my papers, I guess now I'm an assistant professor, but prior to that, you don't want a community person to write your record. That's what I mean. You want an academic person because they know what to write, okay? Always keep your CV updated. Make sure it doesn't have any typos. Make sure it has a good format, very easy to read, and always keep it updated, and you have to give it to your recommender because they can pick out things that are gonna make you stand out. And keep your personal statement. You need to write your personal statement early and keep editing it. Do not wait till the end to write your personal statement. And make sure you have your AMC number or whatever numbers they use now, because usually that has to go into the recommendation letter. So keep that on your CV. So even till now, at my big age, I still have to write my recommendation letters. Like if I have a colleague write a recommendation letter for me for a program or for an award that I'm applying to, they'll be like, write it, we'll just sign it. So be ready to write your own letter of recommendation. And letters of recommendation are different from your personal statement. So again, those are questions you can answer on Google, but be willing to write it. I kind of already said those. Always waive your rights to read a letter of recommendation. Always waive the rights, because if you don't waive the right, that means you're too nervous you actually believe that you're not a great candidate and you need to read it. So waive the rights. And then give them specifics, like, does it need to be on PDF? Does it need to be uploaded onto somewhere? You know, does it need a letterhead? And then always, 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 no matter what someone does for you, always write a thank you letter and do not email it. Handwrite it, mail it. It means a lot, especially to the residents that interview you, because they never get thank you for anything, okay? And they'll remember you. So interviewing, I said I wasn't going to talk about it one-on-one because I have a YouTube video about it, but make sure you do your homework, make sure you practice. That's in detail on that. So what I want to go into is your appearance. So make sure, like, okay, so right now there's a trend of pink suits, teal suits for girls, yellow suits, ASOS and Misguided, and all of them have all these beautiful suits. Those are called attending suits. Okay, you're not going to be wearing your nice pink suit. I collect suits, so I have a lot of the different colors. I'm an attendant. You're not. So I would say when you go, you don't have to wear black. I actually never wore a black suit. I don't own black suits. I don't like black suits, but I wore navy. I wore like suits that were nicely cut, but they were neutral colors. And I didn't want to stand out because you'll be a sea of black people, and I was black suits, and I wanted to wear like my navy suit or my gray suit. That way I kind of, or my pewter, that way I kind of, but it was still neutral. It wasn't like, you know, pastel colors or whatever. So be wary of that, because I think that a lot of people I got a DM about that. I was like, girl, no. Be well groomed, like the way you want to see someone, that's the way you want to be seen. And again, smile, smile, smile. Go to the pre-interview dinner, please. It gives them, and don't drink more than 2 glasses of wine. No one wants a drunk person. But if you drink, drink. If you don't drink, don't drink. Don't start that day. And don't pretend that you don't drink, because actually, one of the questions we were always asked is, I don't drink beer, by the way, but they used to ask all of us, would you drink a beer with this person? And then they will look at me and be like, would you take a cocktail with this person? Because they know me. So you want to make sure that you're yourself. In all of this, be the best version of yourself. Don't be the best version of someone else, because you're also a chooser. And if you go out and you present a wrong like preview of who you are, well, you're going to match as a wrong person. So you want to match into the right program that fits your culture, fits your mission, fits your goals in your life. Make sure you meet the key people. You want to meet the program director. You want to meet the chair of the department. You want to meet the, focus on the 2nd and the 3rd year residents, because the chiefs are leaving and they don't give a crap. They're trying to get a job, trying to match into their fellowship. They don't give a crap about you. And the interns have no clout. Don't mind what they say. They put on their Instagram, they just finished with a robotic, salpingo, oofarectomy. They didn't do crap. They manipulated the uterus. But the people that really matter are 2nd and 3rd year residents, because they're going to go into 3rd and 4th year residents. So they're going to be your seniors, and they're going to be the ones that have any kind of clout. So you want to keep that in mind. And never, ever, ever go to an interview without asking questions. And don't ask cliche questions. Let me give you a big cliche question that you need to stay away from. 2 questions. First one is, do you guys do forceps or just vacuums? It is cultural and regional, okay? I don't do forceps, but I'm a damn good obstetrician. And it kind of puts the program in a weird spot if they don't do forceps. Or do your residents complete all the necessary cases to graduate? What do you mean? Why are you asking them that? They're going to give you a presentation that says that, and they're accredited, so they still exist. That means that so those are like dumb questions. But those are the questions that almost every single interviewee asks. The questions that you can ask are, where is the program going? What are the vision of the program? Does the program want to continue to build in take more residents? Does the program want to continue to impact the community in such a way? Oh, I see that, you know, you guys don't have a reproductive endocrinologist. Where do we go for our REI experience? Those are real good questions, right? There's one thing I meant to say, which is keep your eyes open. Keeping your eyes open, what I meant by that was that every residency program has looked through the list of the current residents. Every residency program has an optimal mission and culture. If the people that you see there look like they could never be friends, and when you interact with them, they look all awkward around each other, that means that that program got a mixed match of people, either people that were couples matching, people that didn't match into somewhere. There's a lot of different things that, because it doesn't make sense. Every residency, like my residency program, for instance, there were like 3 girls from Maryland, there were 2 DOs, there were people that made sense, like they would hang out. And so you want to look at that, because if they're just random people that don't look like they match, well, there are problems with that residency program. So these are some questions to consider asking. I kind of talked about the different types of program, the quality of the program. Ask if there are any research opportunities, if that's your thing, or if you want to go into fellowship. Are there fellowships there? They'll probably already tell you that. Are there fellows present? That is a big issue, because if there are fellows present, you want to know in what capacity you're going to be able to contribute in a surgery. Like for instance, we had a urogyn fellowship, but the resident did the whole hysterectomy. The fellows only did the ancillary things. So that made sense, right? And then you want to make sure that you want to live in this place. Like you're going to be there for 4 years, you're going to have minimal time off. So I went to residency in DC. I'm from DC. It was excellent because I wanted to be able to go home when I could. I wanted to be able to, DC's Chocolate City. I had the time of my life when I wasn't working, when I had my golden weekends. I didn't have to like try to go somewhere, travel somewhere and cut into my, 42 hours off. So that is one of the things. And then people ask me about a second look all the time. You want to do a second look for 1 to 2 programs, no more than 2 programs. Your top 2 programs, you want to impress them. So you want to go for a second look. The reason why I would really say 1, the reason why I say 2 is sometimes you go for a second look and you're like, oh, hell no. This is not what I thought it was. They put on their Sunday's best at the interview, and now this is crap. Everyone is crying in the bathroom. Hell no, it's not for me. Then you want to do a second one, or maybe a third one if that's the case. So the almighty rank list, make sure that you rank based on what fits you. Never ever rank a program you do not want for fear or shame of going unmatched. Don't do it. Don't do it, because you will match into that one. Put your true preference while being realistic. For instance, I interviewed at Yale, right? I first did not want to be in Connecticut, number 1. Number 2, when I interviewed, I don't think there was any DOs there. Number 3, I was like, yeah, I don't think I'm gonna really fit in here. So I didn't match it, right? So I didn't rank it. But people will be like, you're stupid. You could have gone to Yale. Why not? But it wasn't for me. Same thing with Hopkins. I found out that the interns were all publishing before, they were in their second 6 months. First 6 months, they were already publishing. But where I went to Georgetown, nobody published anything. I published mine in my 4th year. So, but by the time we were 6 months in, we had already done like 20 C-sections. You weren't allowed to do C-sections at that time at Hopkins until you were 6 months in. I'm like, those are 6 months of doing surgery. I knew I wanted to be a surgeon. It wasn't for me. I didn't rank it. And people were like, you're stupid. You only interviewed at 9 programs. I only ranked 5. And the 4 that I didn't rank were all like Ivy League schools. But I knew that I wouldn't fit there. So those are ways for you to think about it, okay? Submit your rank list early. Do not wait till all the time the programs crash. So don't wait till the last minute. I don't know much about couples matching. I put that on there because that's not just something I can answer for you. I matched very, very single. I was more single than a dollar. I was so single when I matched. So I don't know anything about that. And then this happened to me. So I got emails and calls from one program. It was one of the programs that I didn't match, so I lied. It was one of the programs I didn't rank. It was, I won't say the name of the program, but they wrote me, they told me that they cannot wait for me to come. They wanted to rank me really highly, blah, blah, blah. And during my second year of residency, the program closed. So beware of people who are very pushy, like pushy car salesmen. Maybe they're trying to get you to save their program. I've also heard of times where they do that. They want people to rank them highly just in case, but they're not planning on ranking you highly. And then you end up with this situation where you thought they told you they were going to rank you high, so you went ahead and put them high, and then you go unmatched. So rank based on you, not them or anyone else's pressure. So preparing for OBGYN, I listed all the resources that you would need for residency. For a medical student, I would say stick to, like, if especially third year when you're going to be doing your shelf exams, stick to doing this stuff like the UWorld. I think I have it on the next page. Case files, John Hopkins manual. I still use that. And then the practice bulletins. The first 2 practice bulletins you should know before you go on any OB floor is about fetal heart monitoring. Because if you knock that out the park, you knock that out the park. And postpartum hemorrhage. Then some of the things that you should know how to do is you should know how to postpartum round. So, because you're going to help a lot with that, postpartum rounding and knowing how to write strip notes. That's why you have to understand these fetal heart monitoring and the management of the tracing. And then I wrote some GYN stuff. The only thing I think I left out of here is ectopic pregnancies. So learning how to manage ectopic pregnancies. So that's really it for me and what I wanted to get through. So I'm gonna start looking at the questions. So if you guys wanna ask them via audio, unmute yourself, or if you wanna write it in, I would love to answer. So someone says, you're welcome. Who's that? What's your name?
It's Cora, I'm talking.
Oh, hey, Cora.
All in feedback. You can't see people, but we're enjoying it.
All right, wonderful. Well, I'm used to talking to myself, being a podcaster. Jesus. So somebody asked, a colleague of mine, oh, okay, got that in. How do programs view case reports in relation to, a publication is a publication. Of course, if you get a publication in the New England Journal of Medicine or Green Journal, obviously it's better. But having a publication is having a publication. So, yes. So Cora, you asked, would I recommend taking a year off research if you're aiming for a university program? If you have 0 research, I actually would not for OBGYN. If you were going for dermatology, ENT, neurosurgery, ophthalmology, maybe if you're like, well, with DOs, ortho is not that crazy, really out of our reach. So those like really super competitive and you have 0 research and you find a position, you don't have to force it. If you find a position, sure, but not for OBGYN. All right, other questions? Someone asked, can I talk a little bit about malpractice and how it affects my practice? Well, my malpractice, I haven't had any, that's a lie. In residency I had, because in residency you can get malpractice, a malpractice suit. I had one lawsuit, not against me. I was actually, my name was on the chart, so they actually ended up calling me and telling me that I didn't need to be followed through. But it hasn't really affected me at all. One of the things that a lot of people talk about, like getting malpractice insurance with a tail in case you leave the practice, and like now I'm no longer a resident, but I got whatever I got as a resident. I got whatever I got when I worked my first fellowship job, and then what I have now is pretty hefty because I'm solo. And I'm very, 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 very picky. The OB patients, if I see like you get, I only do really, really normal pregnancies. So I would just be like, oh, I'm a solo practitioner. You're too complicated for me. Here's a referral. Bye. Like, I only do, like, I'm very realistic at the approach. I do hysterectomies, myomectomies. I have patients that I'll tell them, you gotta lose 20 pounds before I can do your case. They can go wherever they wanna go, but so I'm very careful in my case selection. I opened my practice 2 years after residency. I did a lot of surgery in residency. I worked my butt off. I took a lot of people's calls. You know, I was single, so I did whatever I had to do. And then my fellowship year, I worked in Oklahoma. I didn't know a person in the state. All I did was operate all day, every day. I was the only fellow there. I was operating with everyone all the time. I was on call all the time. So I felt very comfortable. The parts that make you uncomfortable is if you're not a good surgeon, because you can learn everything else by reading. You cannot learn surgery by reading. You got to do it. I'm actually getting nervous not having operated. I operated on April 7th. That was the last time I operated. I was texting my friend yesterday that I'm going through withdrawal. Oh, so I do a lot of fibroid. I specialize in fibroid management. So sometimes I'll operate 5 days a week. Some days I'll operate but when I say I operate 5 days a week, that means I have really long days, because that means I operate before starting clinic, or I operate and then come to clinic and work the rest of the clinic, because I'm by myself. So right now I don't have any I'm the most junior GYN in the hospital. So I take whatever they give me in terms of schedule. I don't have a set schedule. There are people that have set schedules. And because I don't do a lot of OB, and OB is where the money is. So I'm broke, but it's fine. Oh, MFM. I don't know much about MFM because I never cared for it. As you can see, I'm not like, okay, so let me back up. Everyone is different in OBGYN. So they see themselves differently. So there are people who are like, I'm an obstetrician that does surgery, that does C-sections. That's it. There are people that see themselves as, I'm a gynecologist that has to operate, oh my God, has to, deliver babies, oh my God. There are people who see themselves like me. I see myself as a surgeon that delivers babies here and there. So everyone is different. So MFM has a lot of fellowships, so it's not super competitive, but remember you're a DO, so the funnel keeps getting smaller. There are lots of fellowship programs. I would say, like, once you get into residency, don't think about getting into fellowship. Don't jump the cart before the horse. What I would say is make sure that whatever you're going to rank highly is a program. Those are programs that have matched people into MFM before. You're not going to be a novel person. For instance, there was a program that I went to. I clearly did not rank this program, but one of the chief residents found out she did not match GYN oncology the day before or the day of the dinner, the interview dinner. She broke down at the interview dinner because she was drunk and blamed the program. And then one of the questions I asked her in her drunken state was, so has anyone else matched into GYN oncology from your program before? She was like, no. I'm like, well, duh. So you're not going to reinvent the wheel. Like, you know, yes, there are some people, like I remember my residency year, like no one had matched into REI, but then one of my, I think I was a second year when like 4 people matched into REI. So I knew there was potential, but you know, you're not going to be the first person to like recreate everything. So MFM, so back to the question about MFM, it's, you know, look for programs that have already matched people into MFM. You, during residency, you want to make sure that you let them know, let your program know, I want to do MFM. You know, MFM is a lot about research. So you want to make sure you do a lot of MFM related research. There are a lot of things you can do actually on the, on OB. Like there's a lot of databases that you can just analyze things and get your research. And if you already have, like my program is like a big MFM program. So a lot of people, you'll have people handing you out projects left, right, and center, and everyone matches all the time. So that's kind of what I would say. What advice would you give to incoming third years interested in OB who have had OB as their first clerkship, especially during the COVID crisis? Oh, that's a really good question. So if you have OB as your first clerkship and you want to go into OBGYN, ask if it can be changed. If it cannot be changed, I would never, ever, ever tell anyone who wants to go into OBGYN to do OBGYN as their first rotation as a third year. I would strongly advise against it. And here's why. I want anyone that wants to go into OBGYN to do surgery first. Because I didn't want to go into OBGYN then. And I'm telling my most embarrassing story. I fainted at my first C-section. Number 1, I fast a lot, so I didn't eat. Number 2, you have no idea how hot those lights are. Number 3, I think the amount of blood, because it's actually a really rough surgery, I fainted, but look at me now. So I think that doing surgery first will allow you to understand like how to behave, how to scrub in, you're not nervous, you know how to stay these long days. That's what I would suggest to do first. But if you already have it first, then I would say read the practice bulletins that I listed for you. And they're going to be a lot more accommodating because you're first. And we'll see what they do in terms of your school, particularly. What is the process of setting up a solo practice? Do you think a solo practice will still be a valuable option? I actually don't. I wrote an article about that today. I don't know why. I woke up early and I wrote an article about it today. I actually don't think that I'm going to survive this COVID pandemic long enough. I think I'm going to probably have to join a multi-group practice, like where it's all solo practitioners, but they're all part of a multi-group. I actually think that's the best way to, if I could do it again, that's the best way to set up a practice, is to be affiliated with a medical association group, because they take care of a lot of things. And you might have to give up a lot of your profits in the beginning, but it really helps over time and there's a lot less headache. The process of setting up a solo practice was hard and arduous, and I didn't work for 6 months, and I just set up a practice. And ask me in 2 years, because I'm still bitter.
Dr. Rumula, why did you choose to open it up in Texas?
Oh, it's easier. It's easier. And my cost of living, like my apartment in DC is like $2,100. My apartment here is like twice the size and it's like $1,400. So there are other reasons too. But it's easier and the rent is less and everything is cheaper in Texas and bigger. That's why. Work-life balance, there's no such thing. I don't know why people keep talking about work-life balance. I'm lying. They're lying to you. There's no such thing as work-life balance in general. right? Like, unless even dermatology, like there's no work-life balance. You are a fellowship, you are a resident. There's a reason why you call it resident. You live there. I'm gonna be blunt and tell you that there's no such thing as a work-life balance. I think that what will happen is that you will work a lot and then you will enjoy life when you can, and then you will work a lot and you will enjoy life. So that's where you find the balance. But OBGYN is kind of the worst. Like, residency was hell, I can't lie to you, but the rewards from it were great. The rewards every time you deliver a baby for someone and they think you're the best thing on the face of this planet. You know, running a solo practice, I'm on call right now. I'm on call 24/7, but I don't get called that often because I take care of my patients and anticipate a lot of things that could go wrong. But if something happens right now, I got to leave y'all and go, right? So that doesn't make for the best social life. But I think that if you love OBGYN, you love it. You can't even do anything else. You just can't. So those are the people that are called for this profession because this profession is difficult. Now, as we're getting older and it's becoming more female dominated, we're thinking more about how to make it more friendly for taking care of kids and stuff like that. So I have like friends who own practices, they keep hiring more mid-levels so that they all go home, last patient at 2:30. And then if you're on call, you're on call. But, you know, like they all go home, they pick up their kids from school, they start right after they drop their kids. I have another solo provider who works from 7 to 3 only because, I mean, she'll come in to deliver her patients, but she only sees patients in the office and she's a huge booming practice by herself, but she has gotten really efficient. So everything is different. There are people who do laborists, hospitalists, office only, surgery only. I mean, there's so many options. Someone said, as someone who's interested in GYN and women's health, non-surgical, more so than OB, do OB/GYN residency have space for a GYN-centered person to grow? Not in residency. In residency, you're an OB, like, but you're getting the experience that you need. I do 90% GYN now, so that's my choice. When I finish, when you finish, you have all the choices, but it's like medical school. You can't be like, I want to do OB/GYN, so I'm not going to do surgery. I'm not going to do medicine. I'm not going to do, you've got to do all of it. And then residency is a job, but it's still training. So that's that. And I learned a lot of GYN after I graduated from residency because residency is like 70% OB, maybe 80% OB. Do you have any recommendations on what specialties to do? Oh, good question. I think that subspecialties to do, urogyn, GYN oncology, and MFM are like the 3 top ones because they're all based in the hospital. REI is great, but most of REI are not, that's reproductive endocrinology and infertility, which are the fertility specialists. They're all office-based. So you don't get the same clout that you get from those people to write you recommendation letters. Most of the GYN oncologists have a lot of clout because they're the best surgeons of the pelvis, period, because they get 4 extra years after residency of fellowship. Urogyn gets 3 extra years and they are also pretty influential. So those 2, MFM, 3 extra years also. So those are the ones I would suggest. Any other questions?
I have a question. It's Cora.
Did I miss somebody? No, I just got, let's see. I think I got all the questions. Oh, sorry, there's somebody.
Yeah,
We get letters of recommendation for any ones we do. Oh, get your letter of recommendation from a program director because they're recommending themselves. They're recommending you to themselves. So that's one option. And then, of course, if you're like, for instance, I did an MFM at Georgetown, Dr. Zilberman, he's not there anymore, but he wrote my recommendation letter. I did with the, even though I'm telling you not to, I did with the REI because I thought I was going to become an REI. And she was very influential in the entire region. So she wrote my recommendation letter at Christiana because, you know, I was in South Jersey. So I did Maryland, South Jersey kind of thing. So how will OBGYN be impacted by the COVID crisis? I think that every specialty is going to be moved towards telemedicine. So I do some of my patients telemedicine. I do sexual dysfunction, menopause management, and contraceptive counseling via telemedicine because I don't have to touch the patient for any one of those. Even when I saw them, I never touched, or for infertility workups, I can do that without ever touching the patient, right? So that will be a thing. I kind of, on an obstetric standpoint, I kind of wondered this. I think that it's going to probably go more towards a midwife model where people are delivering at home. I think that will be the OB portion. I think that, you know, the thing about it is I've always thought that OBGYNs, MDs and DOs are going to become supervisors. That's how the military is already set up. So the military, family medicine OB, like fellowship trained OBs and midwives run labor and delivery. The OB is only on call for C-section or for like bigger lacerations or operative vaginal deliveries because none of those mid-levels can do any of that. So never get worried that you're not going to have a job because at the end of the day, they can't do half the stuff that you can do. Nobody can do surgery but a physician, period. So there you go. They'll always need you, and they'll always need you for any kind of complications. Anytime they need to deliver a baby fast, they need you. So that's my 2 cents. Somebody asked, well, how do I, oh, my fellowship, it was not a accredited fellowship. I still got paid a lot of money. It wasn't like a regular fellowship because AAGL does not have its own. So AAGL is the American Association of Laparoscopic or Gynecologic Gynecologic Laparoscopists. So they don't have accreditation. So if you do a fellowship with them, you don't have an accreditation. You could just say, oh, I'm fellowship trained. And they do much bigger surgeries. The kind of surgeries that I wanted to do were fibroid-related surgeries. So I just went to a place that has a lot of fibroid-related surgeries, a lot of hysterectomies. I was doing hysterectomies like 4 to 6 a week. So that's what I did. I don't recommend, I didn't need a fellowship. I wouldn't recommend anyone going into a fellowship just to go to one. Like, I don't know where, so you guys are first and second years. So by the time you go into residency and then you're like 6 to 7 years away, the model would have completely changed. Any other questions? All right, my dears, it was a pleasure meeting you guys. I'm gonna send Cora the PowerPoint so that you guys can get all the information. I put the numbers of the practice bulletins to the right because they change often. So like, because they're always updating one every single month, a new one, either a new topic or an older topic is updated. So the numbers may not matter by the time you're, if you're first year, by the time you're there or whatever.
Thank you so much, Dr. Rumala. This
You're
was so
welcome.
helpful.
So much. We really appreciated it.
Oh, wait, there are more questions. Oh, thank you so much.
Yes,
Oh,
thank
yeah.
you so much.
Thank you guys. It's been my pleasure. I'll give you guys all this stuff. Remember, the interviewing part, if you're interested, it's on my YouTube. I put the link to it in the actual video for interviewing. Other than that, that's it, really.
It was great. Thank you.
You're
Have
welcome.
a lovely rest of your day. Great.
Bye.
Bye.
Bye.